We're going to start the next session focusing on what should we know, what cardiac surgeons should know about the medication. We're moderated by Dr. Mihalovic and Dr. Asai.
Yeah.
You can introduce.
So
Starting from keynote speech.
Yeah, Dr. Verma from Toronto is going to tell us something about the Ozempic revolution.
Please tell us what's
Oh, great. Well, thank you so much. I'll try to make up a little bit of time. It's my first time to be at this meeting, and I'm very delighted to be invited. Thank you for the opportunity. And the topic that I was given was to talk about something on the pharmacology side around the Ozempic revolution. Will it change the landscape of coronary surgery? These are my disclosures. I was involved in many of the clinical trials that I will share with you today. So no matter where you live in the world, I think you've heard the word Ozempic. It has changed the landscape of weight. It has been put forward as a strategy for telomere extension and anti-aging. It has also led to the first strategy that the FDA has approved to reduce the risk of coronary heart disease events in people living with overweight but without diabetes. And on the backs of this, the company that makes Ozempic is the most valuable company in Europe across all specialties. So some of the points that I'd like to make today are, will this class of agents reduce the need for coronary revascularization? Is it a strategy for secondary prevention post-CABG? Will it improve heart failure outcomes post-CABG? Will it improve perioperative complications such as ventilation, length of stay, atrial fibrillation? Could it be used as a prehab strategy? And are there other additional benefits that we as a community should be aware of? Well, I think there's no surprise that there's a burgeoning burden of overweight and obesity is at the root cause of many of the cardiometabolic consequences that we deal with day in and day out. And this class of medication, which now includes not just GLP-1 receptor agonists, but GLP-1 receptor agonists along with GIP agonists or antagonists, glucagon agonists or antagonists, the so-called double and triple incretins, have effects beyond A1C and weight. They have effects that are hemodynamic, they have effects on coagulation, they have effects on inflammation, and they also have effects on satiety and diureses and natriureses, etc. So a lot has been written about how semaglutide and its brothers and sisters cause weight loss, and this is the what most people know about these class of medications is that, they're profound medications to facilitate weight loss. And they indeed, in people living with or without diabetes, cause quite profound reductions in body weight. We have also shown in work that we've done that these drugs actually are associated with anti-inflammatory benefits. They reduce CRP by about 40 to 50%, regardless of the degree of weight loss. And in people living with diabetes, in two trials that we've done called Sustain 6 and Pioneer 6, these were people with diabetes who had ASCVD or vascular disease, that the use of semaglutide was associated with a 25% reduction in major adverse cardiovascular events. I would like to highlight for you that in people living with diabetes that actually constitute a large number of people that we revascularize, that rates of coronary revascularization were significantly lower with hazard ratios of 0.68 in people who received semaglutide versus placebo. So certainly appears to be changing the landscape of the need for coronary revasc, primary or secondary, in people with diabetes. Will this emerge as a strategy that we should be using post-CABG to improve our outcomes? And I would start by reminding you all that many leaders in the field like Sigrid and Mark, Ruel and others have written about the importance of secondary prevention as a tool to be just as important as surgical technique. And many of you have seen data from Syntax and other trials that demonstrate that optimal medical therapy, in the benefits of optimal medical therapy, whether it was in CABG or PCI, are markedly larger than the actual difference between CABG or PCI per se. So this is a very important thing that we often overlook. The last scientific statement from the American Heart Association is dated. We are currently working on an updated document that hopefully should be available soon around secondary prevention pharmacotherapy to improve outcomes in this population. I remind you that CABG outperforms PCI in the Syntax trial, as you can see here, even in the face of lower rates of antiplatelet, lower rates of dual antiplatelet, lower rates of statin, lower rates of beta blockers and ACE inhibitors, suggesting that the true benefit of CABG versus PCI cannot be appreciated without us having matching, PCI versus CABG background therapy, respectively. So with that in mind, we did a large trial called SELECT in 17,605 patients without diabetes who had ASCVD and, had overweight or obesity, of which 2,000 actually had a history of coronary artery bypass graft surgery. You can see here that those randomized to semaglutide versus placebo had a 20% reduction in major adverse cardiovascular events. Again, this was the basis upon which the FDA, the EMA, and now Health Canada have given an indication for semaglutide in non-diabetic people with overweight to reduce major adverse cardiovascular events. And the benefit was seen to be similar in males and females, despite the fact that females lost more weight compared to males, and we presented this at the ESC meeting earlier this year. Other outcomes that were of interest, you can see here rates of coronary revascularization and nephropathy composite, death from all causes, non-fatal MI, were all reduced with this therapy in people without diabetes who had vascular disease. A few months ago, actually last month at the American Heart Association meeting as one of the late-breaking presentations, we presented the results of the CABG cohort from SELECT. And as you can see here, people with a history of CABG, of course, have an ongoing persistent risk if they're randomized to placebo for major adverse cardiovascular events, CV death, non-fatal MI, heart failure hospitalizations, and cardiovascular death. But there appears to be a consistent benefit of semaglutide in people with a history of CABG versus those without a history of CABG, with greater absolute risk reduction in those with a history of CABG, and a greater benefit in terms of absolute and relative terms in terms of reduction in non-fatal myocardial infarction. Is this a strategy to improve outcomes from heart failure in people with bypass surgery? And I'd like to remind you all that people with a history of CABG have a significantly higher risk of heart failure outcomes with reduced or preserved ejection fraction. And we have shown this in pooled analyses from DAPA, HF, and DELIVER, two trials that brought SGLT2 inhibitors to the use of HFrEF and HFpEF, respectively, that the hazard ratio for heart failure or CV death in people with CABG and heart failure is 1.31. So the question is semaglutide an anti-heart failure treatment in addition to an atherosclerotic treatment? And in the sort of analyses from SELECT recently, we've published in the Lancet data that suggests that regardless of ejection fraction, in people with ASCVD, there is a significant reduction in heart failure outcomes with this strategy. The concept that heart failure is a major driver of obesity is a major driver of HFpEF has been around for many years. The question is, can we treat overweight and obesity to improve heart failure outcomes? And we studied this in the STEP HFpEF program. These were two trials that we've done over the last 2 years, both of which were published in the New England Journal of Medicine. They have led to a change in guidelines last week, where semaglutide is now indicated to improve quality of life outcomes in people living with heart failure and preserved ejection fraction who have overweight or obesity. So now representing the third pillar of treatment of HFpEF after SGLT2 inhibitors and finerenone. And we've done a pooled analysis of the various trials looking at the HFpEF subgroup and demonstrated that people who get semaglutide by virtue of weight loss and other non-weight related benefits are associated with a 31% reduction in CV death or heart failure events. Now, what about perioperative outcomes? Weight, visceral adiposity is really important, not just mechanically, but also through different inflammatory mechanisms to modulate some of the perioperative outcomes we see. So we have shown from the STEP-HF program that these are anti-inflammatory strategies. Many of our perioperative complications are driven by inflammation, and that also people with atrial fibrillation seem to be exquisitely poised to derive great benefit from these strategies. Furthermore, in analyses from STEP-HF, the echo sub-analyses that we've published recently, you can see that there is a marked reduction in left atrial size, left atrial volume indices, and also an improvement in right ventricular systolic pressure in people who get this strategy. So this would suggest that this may be a therapy to prevent incident atrial fibrillation, which, as you know, is a problem that we all encounter as cardiac surgeons. There's limited clinical trial data at the present time. There's some meta-analyses that suggest that semaglutide may reduce incident atrial fibrillation, although whether this may have application to our population remains unclear. We deal with kidney disease both acutely and chronically in our patients. I think it would be important for us to recognize that these are therapies that reduce end-stage renal disease outcomes. This trial in people with diabetes was stopped early because of overwhelming benefit in favor of improved renal outcomes and reduction in major kidney events. Finally, are there other benefits of this therapy that we need to consider? Now, there's lots and lots of data that suggests that GLP-1 RAs are very strong neuromodulators. And in fact, those of you who are interested, you should read this paper in Cell Metabolism. It's a wonderful review that talks about how GLP-1 programs the neurovascular landscape, and that how it actually may have a primordial role to facilitate oligodendrocyte progenitor cell differentiation, the cell type that lays down myelin, while at the same time blocking immune trafficking that actually is the process that chews away at myelin, and therefore this may be a strategy to actually improve cognitive function. Indeed, meta-analyses suggest that this strategy, compared to other strategies in diabetes, improves cognitive function, and in fact there are two trials, I'm not involved in these, that are currently ongoing, EVOKE and EVOKE Plus, to evaluate outcomes in cognitive function. But one of the most exciting aspects of this biology appears to be the addictive behaviors, something that all of our patients have to deal with post-surgery, and that is risk factor modification. There's a large body of research that has implicated GLP-1 and GLP-1 receptor agonists as core targets, essential targets that actually modulate reward behavior, and that are targets for substance abuse, data with semaglutide and tirzepatide reducing alcohol consumption and nicotine addictions, etc. And this goes back to the biology of GLP-1 and how that interacts with the nucleus accumbens within the frontal cortex, the basal ganglia, and how it actually regulates the NTS pathway, both involved in alcohol-induced reward and alcohol intake. And therefore, there's a large body of clinical trials now specifically evaluating that. Finally, these are regenerative therapies. They regenerate vascular stem cell pools. Our work and others have actually, laid the foundation in humans that vascular progenitor cells destined to repair the endothelium, their flux is improved with this biology. So to conclude, a story that really started with sugar and A1C control and then went to weight has now expanded to the pump, i.e. heart failure, the pipes, i.e. atherosclerosis, and the filter, i.e. renal disease, and really a strategy that we thought was just going to be for people with diabetes and a strategy to lower weight has really turned into a formidable therapy for cardiometabolic risk reduction. Many ongoing trials are currently, there's about 9 that are currently ongoing that will hopefully define this era of GLP-1 based therapies in heart failure and vascular protection. I'm involved in the TRIUMPH Outcomes trial, which is a large trial of 10,000 patients in this regard. So the question that I was given, does this represent a revolution, and will it change the landscape? And I think the answer is it most likely will, and whether we like it or not, we're going to have to learn about this. Thank you very much.
Thank you, Dr. Verma. Thank you for this fantastic overview. I think you can join us here at the podium, so and we can discuss this together before we move to the next lecture, which is going to give us by Dr. Myers about the new guidelines and the optimal medication therapies. I just want to add one comment. I think this is very promising strategy for sure. We have just preliminary data. We need to see what is the role in the prehabilitation and the secondary prevention measure. But I also have one word of caution for all of us who are using this treatment before cardiac surgery, because this treatment also provides the delayed gastric emptying. So the American Society of Anesthesiologists recommend skipping the last dose of Ozempic, which means that this last dose of the Ozempic should be skipped in order to prevent aspiration during the induction of anesthesia. So this is just one practical tip. So Dr. Myers, please proceed with your lecture, and then we can discuss, I think, the entire topic together.
Well, a very tough act to follow. Outstanding presentation. Yeah. So I'll talk about optimal medical therapy, what our latest guidelines say. And actually, I think Milan would be much better suited to give this presentation, since he was involved in the chronic coronary syndrome guidelines that were presented at the last ESC meeting. And we recently have in print our own perioperative medications guidelines, which I'll be discussing. Now, I have no financial conflicts of interest. Now, we're surgeons. Why should we be worrying about medical therapy? I mean, shouldn't we just be in the operating room operating? Well, I don't think so. I think we just had an outstanding presentation this morning, and also yesterday morning, Patrick Sois showed us how our landscape is going to change with medical therapy. Also, just looking at the process for the North American guidelines for coronary disease, we saw that the ischemia trial was used to influence the recommendations. And here, this trial was a strategy trial, which was looking in patients with chronic coronary syndrome with, it's true, low complexity disease overall mostly, but that an initial conservative strategy, meaning just medical therapy, was had equivalent primary outcome to an initially invasive strategy. So medical therapy is actually really good. It works well for our patients, and I think we're all here for our patients more than anything. Unfortunately, that was used to downgrade the recommendations for multivessel disease and the indication for CABG, whether it be in reduced ejection fraction or normal ejection fraction, and essentially based on the ischemia trial. Why do we need to worry about medical therapy? Well, because it improves outcomes. And as Dr. Verma showed just before, if we look, going back to the syntax extended survival, this is from the 5 to 10 years. So this is obviously a selected group of patients. It's not the whole cohort. But we see that the more patients were on medical therapy, the better the outcomes were. And we also see that it depends on which medications it was. Looking at antiplatelets and statins, we see that a CABG patient who is not getting this medication actually has much worse outcomes than a PCI patient. And it's only because they're getting medical therapy that their results, their long-term outcomes, are better than the PCI patients. So if we're not giving optimal medical therapy to our CABG patients, we're not giving them the best options for their long-term survival and good outcomes. And as the previous speaker showed very well from the syntax trial, overall, our surgical patients are getting much less optimal medical therapy. So we need to do better. So looking at the guidelines, and I'll try to do this relatively quickly, let's say that there are 3 different goals of medical therapy in coronary artery disease. First is overall reducing cardiovascular risk. The second is symptomatic relief, and the third is prevention of events. And for us, that's their secondary prevention after CABG. Going very quickly, since this is more of a cardiology topic than a post-surgical topic, but of course we need to reduce cardiovascular disease risk, having a multidisciplinary behavioral approach, exercise-based programs with some goals on aerobic physical activity, and a slightly less strong recommendation with a 2A recommendation for at home cardiac rehab. In terms of symptom relief, I won't go into the details of the different anti-anginal agents that we can use, but overall, for immediate relief of angina, short-acting nitrates, and for the background treatment of angina, beta blockers or calcium channel blockers. But coming to what interests us more as surgeons, how to prevent events in our patients with coronary artery disease. And we have these 5 classes of medications. In terms of antithrombotic drugs, we have so many different options, but looking at the recommendations, it's essentially we still are on aspirin, low-dose aspirin, 75 to 100 milligrams daily. And in patients, I think especially the last line of the first table, that we can consider in patients with a particularly high risk, thrombotic risk, to add in a second antiplatelet agent. And for the very last line of this recommendation, that we can consider DAPT after CABG in selected patients at greater risk of graft occlusion and with a low risk of bleeding. That's a level of evidence B and just a 2B recommendation because we really don't have much data, and hopefully we'll have some significant trials that are ongoing to orient this. Also, the other element that I went over is the fact that if your patient has an indication for anticoagulation, a VKA or a DOAC, for example, atrial fibrillation, well, that's an indication to discontinue the aspirin, or you may increase the risk of bleeding. In terms of the lipid-lowering drugs, we have different target levels with an LDL-C lower than 1.4 or 50% reduction from the baseline. And looking at different options of adding on ezetimibe on top of high-dose statins. And if, even when that is not enough, as usual, we would consider PCSK9 inhibitor. Of note, the last line that when we have patients who are at particularly high risk of events, if they've already had a recurrent event, we would go for even lower target LDL-C goals. In terms of renin, angiotensin, and aldosterone blockers, here we have a class 1 recommendation. However, it's not in all patients. It's only in patients that are at higher risk, that have specific comorbidities, such as hypertension, diabetes, or heart failure. And we just had a fantastic overview for SGLT2 inhibitors and GLP-1 receptor agonists, so I think I will go over this quickly since we've already gone into much more detail. And our next speaker will talk about anti-inflammatory agents, so just mention that it's a 2A recommendation that we should consider colchicine in patients with atherosclerotic coronary artery disease, with the goal to reduce MI, stroke, and need for revascularization. One last more specific element is we use increasingly arterial conduits, and particularly the radial artery is a very muscular conduit that is prone to spasm, and so these require specific treatments. And in our consensus review for the radial artery, we do say that there's observational evidence that supports the use of vasodilators for the first year in patients with an RA graft, and that it should have an influence on the long-term patency of these grafts. So what should we be using optimally? Nifedipine or amlodipine. Verapamil can depress the myocardial function and conduction, so should be avoided. And this is just looking at the results, or the what we have like data for the moment, which is essentially small trials and mostly observational data from larger trials that would tend to show that the long-term patency is better using these calcium channel blockers. We had the privilege of having the ASREB pilot trial that was presented as late-breaking 2 years ago in Vienna. But here, since it's a pilot trial, we have a relatively limited number of patients included, and probably not enough power to detect a significant difference. And we didn't see between the different agents used any difference in terms of the RA graft failures. But hopefully we'll have more data coming from the group in their more extensive trial. So why should surgeons worry about optimal medical therapy? Because it helps our patients, and bottom line is we're here to help our patients. So please, when your patient goes home after CABG, he or she needs as much medical therapy as he can tolerate. That's what's going to improve their outcomes long term. Thank you very much for your attention.
Thank you, Patrick. Please join us. We should continue further and then save a few minutes at the end of the session for discussion. Our next speaker is Hristo Kirov from Jena. So he's going to tell us more about whether the colchicine should be the standard of care to prevent postoperative atrial fibrillation. Thank you, Kirov.
Thank you very much, dear Chairman, ladies and gentlemen. I'll start with a bit of history. Colchicine is an ancient drug, and actually it was used to treat gout and rheumatic disease for centuries. It was first mentioned in this papyrus 1,500 years before Christ. And just by any chance, this papyrus is kept just around the corner in a university library near to the place I work in Jena, Germany. So it's produced and extracted from this beautiful plant, the autumn crocus, and it's actually very cheap and easy to produce. It has a strong anti-inflammatory function. It can inhibit microtubule polymerization and mitosis. It can stop neutrophils from becoming activated, degranulating and migrating, and therefore it exhibits its anti-inflammatory effects. However, it has some adverse events, or it may have them, primarily digestive, including nausea, vomiting, and diarrhea. And in excessive serum concentration, it may lead to serious adverse events such as muscle toxicity or cytopenia. So let's concentrate only on the cardiovascular disease and see what is the use of colchicine there. And there are three primarily areas where colchicine has shown beneficial function. The first one is in the treatment of pericarditis and post-cardiotomy syndrome. The second one is the treatment of atherosclerosis and the prevention of future myocardial infarctions. And the third one is the prevention of atrial fibrillations. And if you consider the only surgical procedure where all three treatment effects combine is CABG, as CABG is indicated in patients with atherosclerosis. Of course, we want to prevent future myocardial infarctions, but up to 30% of the CABG patients exhibit postoperative atrial fibrillation, and they also may have post-cardiotomy syndrome. So the beneficial effects of colchicine combine in CABG patients. And if we start with the post-cardiotomy syndrome, there are three randomized trials that have been published, and they compared the effect of colchicine to placebo. And this is a forest plot from a meta-analysis that was published some years ago. And you can see there was a relative good clinical benefit in the colchicine group with a risk ratio of 0.5. And just to remind you, Mario Gaudino published this excellent review of postoperative atrial fibrillation. As you can see on the left-hand side, it is a complex mixture of factors that contribute to the development of postoperative atrial fibrillation. And two of the main postoperative factors that influence this development are pericardial blood and pericardial effusions and inflammations. And exactly on those factors is concentrated the treatment effect of colchicine. So we'll move further, sorry about it, we'll move further to the treatment effect in atherosclerosis. There are a number of randomized controlled trials, and I'll show you two of the biggest that have been published so far. The first one is the COCO trial that randomized almost 5,000 patients, 4,700 patients in a 1-to-1 ratio after myocardial infarction. And for the primary endpoint, which was death from cardiovascular causes, resuscitated cardiac arrest, myocardial infarction, stroke, or urgent hospitalization for angina that lead to coronary revascularization, colchicine was significantly reducing the cumulative incidence, and this year in Circulation, a very interesting subgroup analysis from this study was published that compared the results of OCT investigation of patients in both groups, and this analysis showed that actually colchicine has favorable effects on coronary plaque stabilization, and thus probably this is one of the mechanisms how it prevents future myocardial infarctions. I have to be fair and say it is not published yet, but this year we presented the data of another big randomized trial that analyzed the effects of colchicine in ST elevation myocardial infarction, where colchicine showed no significant effect. But this has not been published yet. But if we move from the acute setting and go to the chronic setting, in chronic coronary artery disease, there is also good randomized data. This is the LODOCO-2 trial, where 5,500 patients with chronic coronary artery disease were again randomized and assigned either to 0.5 milligram of colchicine once daily or matching placebo. And the primary endpoint that was analyzed was a combined endpoint of cardiovascular death, myocardial infarction, ischemic stroke, or ischemia-driven revascularization. And as you can see here in this Kaplan-Meier curve, there was a significant difference in favor of colchicine between the two groups. So if we concentrate on the secondary endpoints, apart from that combined endpoint, we could see that even analyzing cardiovascular death or myocardial infarction, colchicine was superior, as well as analyzing only myocardial infarction, colchicine was also superior. It was superior for the endpoint of ischemia-driven coronary revascularization. And if we take a look at the new onset or first recurrence of atrial fibrillation, there is no statistical significance, but there is a strong signal that colchicine might also be beneficial. So if you see here on that graph, this is the relative risk reduction of colchicine in the COCOT and the LODOCO-2 trials compared with two PCSK9 inhibitors or with ezetimibe. That's why I say colchicine is a drug without a lobby. It's very cheap, and I cannot read that Egyptian papyrus, but if the Egyptians patented it 3,500 years later, that doesn't count. So compared to the thousands of euros that PCSK9 therapy costs, it's a very cheap and efficient treatment. So far, it has been unknown if the effect of colchicine is beneficial in CABG patients. But what we know, and we have analyzed this with our group in Jena, is that post-operative atrial fibrillation have a significant effect and are associated with greater mortality, perioperative mortality, stroke, myocardial infarction, acute renal failure, hospital and ICU length of stay, but also with the significant adverse long-term events as mortality, stroke, and long-standing atrial fibrillation. And in order to see if colchicine has a beneficial effect in CABG, we also performed a meta-analysis, and we analyzed 205 studies and could identify 5 randomized trials that provided information on the topic. And you can see here the forest plot on the effect of colchicine on post-operative atrial fibrillation post-CABG. We have a significant risk reduction with a risk ratio of 0.45 and a confidence interval between 0.4 and 0.7. So to answer the question, should colchicine be the standard of care to prevent AFib in CABG patient? I think yes, but not only to prevent AFib, as it has beneficial effects that might also include reducing future myocardial infarction, reducing post-cardiotomy syndrome. And as recently, a huge randomized controlled trial has been published about the effect of colchicine in thoracic surgery. Now I'm asking, when will we do the first randomized controlled trial evaluating the effect of colchicine in CABG? Not only on postoperative atrial fibrillation, but also the long-term effect on myocardial infarction. There is currently no data on graft patency, and this is a significant gap that we have to fill. So I would like to conclude. There is a strong randomized evidence suggesting a beneficial effect of colchicine in patients with coronary artery disease, such as CABG patients. There is a randomized evidence suggesting a beneficial effect of colchicine in reducing post-cardiotomy syndrome, which is relevant for CABG patients. And there is randomized evidence suggesting beneficial effect of colchicine preventing postoperative atrial fibrillation after CABG. However, one should be aware of the possible gastrointestinal complication. Thank you.
Thank you, Peter, please. So our last speaker, I cannot see him in the room. So it's Michael Fakuch, and should talk us about blood pressure and the statins, but he's not with us. So we'll have some time for discussion. Otherwise, we'll not have a discussion at all. So maybe I can give the first and the starting the comment for the very last talk from Christo. I think it's a colchicine. It's something that is extremely promising, but not well studied in cardiac surgery. Like, for example, we have randomized data in thoracic surgery. We have a large randomized trial, which is actually negative over there. And unfortunately, this CLEAR trial was just published in New England Journal of Medicine 15 days ago, and was completely negative. I also want to also raise attention about these gastrointestinal complications, which are quite often. It's about the 10% of patients, they have a serious diarrhea, and about 20% of the others, they have other gastrointestinal complications. But I think effects are there. We just need to have a very large study to prove them. And we have a question from the floor. The Rakesh, please.
Question. Oh, geez, sorry. Okay. It's almost more of a comment than a question in some ways. That this is all very important. I agree that this is necessary for our patients for post-discharge care, but it is incredibly complex now with all these agents. It's almost like, someone undergoing complex chemotherapy. And maybe that's the way we need to think about this with older, frail patients with a lot of drug-drug interactions. How do we practically do this? For CABG patients in particular, which is the most common procedure we do, and for us in the U.S. where we have low-volume centers that are very differently resourced than probably most of us in this room, how do we practically implement these various therapies for these older adults?
I can take a kick at the can if you want. So, of course, Rakesh always has the most important questions, and I agree with you. At the end of the day, moving the data from the New England Journal to the masses is going to be the Achilles heel. But I would submit to you, it's not that hard. It's not as hard as sort of complex chemotherapy regimens. I think the foundational therapies of, statins and PCSK9 inhibitors and ezetimibe for lipids, and antiplatelet therapy, aspirin and clopidogrel or, ticagrelor, colchicine is evolving. We have a lot of experience with using that, at least in some populations. The diabetes drugs are sure new, and they will require a primer, but I think that's not that difficult. They don't have a lot of drug interactions. We have a lot more comfort using SGLT2 inhibitors in heart failure, for example, in the perioperative management. So I think that can be, But at the end of the day, the fundamental question is, do we think it's our responsibility or not, right? And if we think that it is part of our cocktail and it should be part of our vernacular, then we're going to have to find systems of care. Either there's going to be cardiometabolic secondary prevention sort of clinics that will see patients. The problem with a lot of CABG patients is that, unlike PCI patients that are tied to their cardiologists, many centers throughout the world, after they've been revascularized, the cardiologists sign off as well. So you've got a patient who's left with a family doctor. And if the patient actually had to them tied a cardiologist for the rest of their life, then I think we could probably, expect that background therapies would remain the same. But if you look at the clinical trials in the landscape, not only do they start off at lower optimal medical therapy, but that gap continues to either stay stable or widen over time. And I think that is what, is a big impediment for our outcomes.
If I can just add, so of course we need more research, but I think this is the three-step process. The first one is to produce the clinical practice guidelines that are clear, because we are here talking about guideline-directed medical therapies. So we need to have a clear recommendation to clinicians. And then after, they have a quality assurance and quality improvement. I know that many states, in the United States of America, they have a fantastic quality improvement program, and now they are moving to the goals and having 90+% of patients on optimal medical therapy after cardiac surgery. But I think a critical point is the discharge of the patient. If patients are not discharged on the optimal medical therapy, they will not probably get it from the primary physician or from the other hospital. So we need to secure that those who are discharged, they are discharged on the best possible medications. So we have another question from the floor.
From Belgium, also a question for Dr. Kirov. We all are aware after minimal invasive bypass surgery of the higher incidence of post-cardiotomy Dressler syndrome, and there's also the potential beneficial effect of the colchicine on this topic. Do you have any, or are you aware of new insights or new studies that prove this, what we all think that colchicine should or can do for these patients?
Yes, there is also a guideline recommendation. I think it is a 2B recommendation for the use of colchicine in post-cardiotomy syndrome.
Yes.
So there is strong evidence suggesting the use. And of course, there are other methods to reduce it. I say a posterior pericardiotomy is a good way to reduce also the incidence of Dressler syndrome, which is also associated with a reduction of postoperative atrial fibrillation. So I think it's a complex process. There is not a single medication or a single thing, but I think for the perioperative course, for a short period of time, colchicine has shown a beneficial effect for Dressler syndrome and for postoperative atrial fibrillation. The lacking data is long-term after CABG.
Some studies even suggest to prolong it for 2 to 3 months.
Yeah. That is true. However, if I have to be honest, there is not a single recommendation in those randomized trials. Some trials have given 0.5 milligrams per day, some were given at 1 milligram per day, some were even starting with a dose of 2 milligrams per day, thus explaining why in some studies there was a high incidence of diarrhea, in some others there was no complications. So there is no uniform recommendation. Of course, the recommendation that is in the guidelines concerning the atherosclerotic risk reduction is of 0.5 milligram, and I think that is probably the best way to start is to give 1 milligram as initial therapy and then perform, then continue on 0.5. As what I've read in the different trials is this has a low potential for diarrhea and other complication, but still exhibits an anti-inflammatory effect.
Thank you.
Okay, can I just add something about the colchicine story? I was involved on the steering committee of the Synergy Clear Oasis trial that was just presented. It was just published actually a few days ago.
Oh, okay.
But I think that I don't want that result, as you rightfully mentioned, to sort of take away from the chronic stable CAD data that you've shown, because that's a STEMI population. It's very different in terms of, the types of people that were studied in both LADOCO-2 and COLCUT. And, because that has actually created a bit of tension as to whether colchicine should be used or not as a secondary prevention anti-inflammatory strategy. And there are anti-inflammatory trials that are ongoing. ZEUS is one that is ongoing. I'm involved in that trial. It's with ziltivekimab. It's an IL-6 inhibitor. It's just a couple of streams downstream to colchicine, affects the NLRP3 inflammasome pathway. and that will evaluate atherosclerotic outcomes as well. So there's a lot of biology around inflammation, and colchicine certainly, has a potential.
If I can add to this finding from the clear synergy trial, because anti-inflammatory effects are there, because this is the first trial that really systematically measured the CRP levels in 7,000 patients. So in the reduction of the CRP levels, it's 1.2 milligram, which is tremendous reductions of anti-inflammatory in the treatment group. Professor Taggart, please.
Thank you. First, to congratulate everyone on this session. It's been absolutely super. And I don't often come and really learn quite a lot in a session that I knew very little about. But I have one question. With all of these new trials, with the plethora of all of these new drugs, I presume the beneficial effects against the placebo group, I presume the placebo group were already on optimal medical therapy.
Yes, the answer is yes.
Good, okay, well that reassures me. The second thing is more a logistic problem. This is incredibly complex for the average cardiac surgeon. If you can get a surgeon to prescribe aspirin, beta blocker, and a statin, that's fantastic. You couldn't even get that done in the Syntax trial, and every randomized trial of PCI versus CABG, with the exception of Excel, has shown markedly reduced optimal medical therapy, as was pointed out. So unless there are specialist doctors who can deal with this is way beyond the remit of not only the willingness, but the actual ability of a cardiac surgeon to do this properly. Many of these are very powerful drugs. There's no information. What about the interaction with each other? So, while this is a wonderful advance in medicine, for many of this, I cannot see, certainly in our practice in the UK, that this would be within the competence of the average cardiac surgeon to do this.
I think it goes back to what Dr. Arora just mentioned, right? As a core impediment is how do you take this forward? And maybe it's simple to some of us, but I think you're absolutely right. For the masses and the doctors in the trenches, it's going to be very hard to do. And I think maybe the AATS, SDS, ICC, leaders like yourself and Rakesh and others have to hold seminars or workshops on how do I do it? How do I make this practical, right? Because at the end of the day, we're giving away, in the comparison against PCI, we can't do a proper comparison without having the same metrics.
I need no convincing about that. I often point to that in my talks. But to me, it's what would be the logistics of effectively getting this done? On that, but thank you for answering my question. But again, I'd like to congratulate the whole panel. Absolutely super.
Thank you, Professor Saga. If I can add something to this because this is very important comment, of course. So we have just published the second edition of perioperative medication guidelines at ESCTS. So we have a new guidelines on the perioperative medications, and over there, because realizing how much it's a complex involving all of these medication, as a last chapter, we clearly define what are the guideline-directed medical therapies for the vast majority of population. So over there we propose that the therapy for CABG, for those presenting an acute and a stable condition and valve disease, and then the other medication can be added according to their conditions. But over there, for the first time, we have this combination that should make a life for surgeon easier. And just as a quality check and see if the patient is not discharged on antiplatelet therapy, and of course the aspirin as a first line, statin and ACE inhibitors, so this patient is not well treated. So we need to revise the discharge therapy for this patient. But it is over there, and I hope we will have an opportunity to promote these guidelines in the future because they are very comprehensive and important and developed, of course, with the cardiologists and anesthesiologists. So thank you.
Very good point,
Great session.
We had, apologize.
Thank you.
Please.
Great presentations. I have one question. What are your recommendations, or how do you do it in your centers with dual antiplatelet therapy after CABG?
So we have actually very clear recommendation for dual antiplatelet therapy after CABG. So we have 4 trials. All the trials are negative, but pull them together they show the reduction in MACE, but they also show the tendency of more major bleeding. So this therapy should be reserved for only those who are at high risk of graft failure immediately after surgery. So we don't recommend the APT as a routine after coronary artery bypass grafting, only in those at high risk, like off-pump surgery, or you doing some endarterectomy, stentectomy, or some procedure that really have a high tendency of the graft failure, but not as a routine.
And when do you start the clock?
Yeah, so this is also an important question. Of course, depends on the degree of bleeding, but we recommend within 48 hours. So not a rush immediately after 6 or 12 hours. So we try to stabilize the patient, to exclude the risk of bleeding, and then do this within 48 hours.
And I think there's also some more observational data on vein graft patency with DAPT. So some surgeons use that systematically for vein grafts, even though that's not very evidence-based.
It is. But we'll have a trial now. Actually, it's an ongoing trial that compared the DAPT and single antiplatelet therapy. It's ODIN trial. It's run by Sigrid Sandner and Mario. I don't think Mario is in room. But I think in the next 1 or 2 years, we will have more data in this field.
I think
Maybe
my
the last
question, Joseph Arcidi from Eureka, California. I think my question is kind of lined up with a lot of the ones that you've just heard. I think a lot of us will feel compelled immediately to start aspirin. Those of us who may have had a graft that's very tenuous, a millimeter or so distal target vessel, will want to start Plavix, maybe even that night. I've heard John Puskas talk about that. And so that by the time of discharge, we'll know that we'll have 3 plus or minus an ARB. But when is it in the panelist's mind, and it's really remarkable to have cardiac surgeons who are experts in this area, when is it important to start colchicine? When does the SGLT2, some of these other ones, and I'm looking forward to, is this going to be in that EACTS guidelines?
It is over there. If I can take a few more words, and then I will give a chance the other to talk. What is important is that all of these therapies are initiated before the discharge. If patients are discharged without the optimal therapy, they will not get it. That's our biggest concerns, because what we have observed so far, we have a data from the clinical trials, from 4 trials, the Syntax, Excel, BEST, and pre-combat, and we have a larger data from Sweetheart Registry. So what they have observed over there is that if patients are discharged without optimal medical therapy, so this degree of the optimization just decline over the time. So there is no chance that they will receive the optimal medical therapy at the later period. So in this guideline, I think at least we try to clearly emphasize how much is important to initiate this treatment before the discharge. For example, SGLT2 or GLP-1. Of course, we need to make some delay after immediate period, so we need to wait 3 to 4 days. But just before the discharge, we need to prescribe this medication. Otherwise, the patient will not get it later on.
So if it's, to follow up, if it's a logistic reason, that's one thing, because I, like many of our patients, might see someone the first week after discharge where they're not going to see, at my request, frankly, they're not going to see their primary care doc for that first 30 days because I don't want a lot of interference in their care. Is there a pharmacologic reason why it couldn't be started 10 days after, their operation or something like that? That's kind of important for me to know some of these. I can understand your reason from a practicality standpoint, but it'd be great to know the pharmacologic basis of when is it important to start colchicine, the SGLT2, these others.
So for SGLT2 and colchicine, we are lacking the data to say that it's really beneficial if we start 3, 5, or 10, 15 days afterwards. But what we know for antithrombotics, we need to start them as soon as possible. What we know for statins, we need to reduce the the levels of the LDL as soon as possible. So we don't have a time to tailor the statin therapy, to start with a low to intermediate dose and then to adjust the dose. We need to treat this patient very aggressive from the beginning in order to reduce this 50%, at least for the 50% LDL. We know for the antihypertensive medication, we need to start them as soon as possible. So these medications that are the pillars of guideline-directed medical therapies, they need to be initiated as soon as possible. And the other medication can be tailored, of course, according to the patient, the general condition. And maybe in future, if we have more data, then we can have more specific recommendation about the timing on them.
Thank you. One last point. For a lot of my patients, it's going to be an economic situation. Geez, Dr. Arsidi, I can maybe afford this and this, but I don't know that I can afford these other things. So just something to keep in mind.
Yeah, absolutely. So of course, this best practice guideline does not take the cost effectiveness and cost benefit, but they really keep in mind the costs of all of this. And really combination nowadays of aspirin, the statin, and ACE inhibitor is probably a cost of $10 to $15 a month, not more than that. That the vast majority of people can afford being on optimal medical therapies these days. Any other comments from the
Well, I would just add by saying, the timing of when to restart things after surgery, I agree, the earlier the better, prior to discharge if possible. You've got a receptive patient, you've got a receptive audience, but it's not possible in all patients, right? Some drugs, their pharmacology doesn't allow that to happen. Sometimes, the systems of care won't allow it. GLP-1 receptor agonists, sometimes they're, are not easy to initiate. They're easy to restart if they have been on it prior to surgery, but they may not be easy to initiate per se, because you still have some gastric slowing when you're just immediate post-op on day 4 or 5. So those may be recommendations. SGLT2 inhibitors, we've published the data from EMPA-REG outcome in the CABBAGE cohort. It suggests that patients with a history of CABBAGE who got SGLT2 inhibitors actually had a 48% reduction in CV death, 48% higher than the overall cohort. So again, SGLT2 inhibitors are a cornerstone of cardiovascular protection in people with diabetes who have had coronary surgery. And as was mentioned by a chair, the timing of when you add it is really, the sooner the better, but you shouldn't be adding an SGLT2 inhibitor, until someone has resumed good oral intake, including, carbohydrate intake, because there is a risk of decay, at least in people with diabetes. People without diabetes, who have heart failure, they don't usually develop decay. But I think all of this is going back to, I'm surprised by the level of interest, first of all, and I'm excited to see that. But at the same time, the enthusiasm is tempered because we don't have practical solutions, as Dr. Arora was mentioning, to actually translate this into a sort of an algorithm. And I think your efforts and others in terms of guidelines are moving this forward. But we need a companion to the guidelines to say, what do I do and how do I do it? And what should be the step 1, 2, 3, like a dumb it down kind of guide, that is going to be required for knowledge translation. Because, many of us are more comfortable putting a patient on ECMO than actually writing empagliflozin, you know what I mean? Which kind of sounds crazy, don't you think? But it can't be that difficult.
I think that's a very good comment. That maybe that's a call to action from today's session, is that we should put words on paper and have a practical guide of how to do this.
You need that.
What, when, and
maybe
where.
Maybe a video or something, because people are more inclined to do that. And the other call is, leaders like John Puskas and Mario and many people sitting on this podium who represent the society, leaders like Rakesh from the AATS who represent perioperative medicine, need to really come together as a lobby to companies to say, you need to do clinical trials with pharmacological therapy in a patient population with CABBAGE randomized to this versus that, not sub-analyses of larger trials. Because unless we generate data in our own population with one therapy or the other, we sometimes still hide behind the fact that maybe we're not accountable for it, and maybe it's not as beneficial in this regard. So I think there's appetite at industry. It just requires enough of a momentum for us to be together and say, please, can you do a trial of, evolocumab, a PCSK9 inhibitor in 3,000 CABG patients, or as I showed you the data from SELECT, the 2,000 patients with CABG actually seem to derive much greater benefit than the overall cohort. Exactly. Why not do an a priori clinical trial in that setting?
And another call to action is what we're also working on in terms of associations is getting the industry, pharma industry, to be present at our meetings and educate surgeons. They educate GPs, cardiologists very well. Yeah. And if you look at the exhibition at the AHA, the Edwards and Medtronic stands are tiny. It's the pharma stands are what are most important.
Yeah. In fact, Dr. Puskas and I were just communicating about that through text a few minutes ago, saying that this is a perfect venue for those companies to also be partners in helping us learn the language.
Now, of course, we're very grateful to all of our partners who are here and supporting us, which allow us to have this meeting.
Yeah, of course, yeah.
We had great lectures, 1, 2, 3, 4 lectures. I think this is quite new. It's in the first 10 years history of Coronary Congress, but this is growing part. I'm just worrying about this risk reduction by new medication. Maybe overcome the effect of CABG. CABG is actually the power is a secondary prevention of the non-procedure MI and other stuff. But with this medication, really catching up the CABG effect. One thing, I'm as a cardiac surgeon, I worry. We may not need the CABG in 10 years, 20 years later, because medication goes too far. What do you think? Maybe it's an open question.
Please, can we just, we need a...
We're here for our patients, so if they can avoid a surgery, great. I think the patients will always need some form of CABG, perhaps fewer, but I think that if it's for the good of our patients, well, that's all the benefits for them. Yes. That's what we're here for.
I believe you.
And I think if you look at all the PCI versus OMT, or PCI plus OMT versus OMT trials, they can't show any benefit in terms of mortality, MACE reduction, or anything like that. And we're just treating symptoms in non-blinded trials. CABG has a benefit still today, and CABG has improved. That's what we're working on, more arterial.
Thank you. Well, no question.
Residual risk always persists, right? So there's, no matter how many therapies we have, there's still area under the curve.
Maybe we can have a last comment and conclude the session and
Professor,
coffee.
Just 30 seconds.
Just a short comment.
So I'm not sure in the first world, but like in a more poor country, secondary prevention is just not a reality. So you may lose your jobs, but maybe we'll still keep ours for a little bit longer.
Absolutely.
Well, there's no question. We need to study more and investigate the new aspect of the cardiovascular. It's very, very important. I realized today. Thank you very much.
Thank you. Thank you very much.